Okay, so let me share my screen. If I can find it, a bit disoriented. I've been using Teams this morning and sorry,
No
just
worries,
bear with me.
It's Friday here too.
Okay, I hope you can see this. Okay, the study that I would like to share with everyone today is a feasibility study, a very small study, which is basically a first step of what we're trying to do in the next phase. But in short, we're trying to look at how feasible it is to deliver a remotely delivered, obviously, resistance and balance training program for older adults with cancer. So, is it moving? No. There it is. I have nothing to disclose. So a little bit of background. So we all know that falls are a major issue in older adults in general. Like each year, at least 1/3 of older adults will experience a fall. And falls are actually a bigger concern among older adults with cancer. And it's because of a number of factors that's related to cancer treatment process and also the disease process itself. Just some of the more common reasons here, and this list is by no means exhaustive. Say, for instance, dehydration related to chemotherapy treatment that can obviously lead to volume depletion, and sometimes the patients may experience dizziness. And we all know about chemotherapy-induced peripheral neuropathy, which can actually obviously lead to numbness and tingling, especially if it's in the lower extremity that may not be very good. And also loss of muscle mass related to deconditioning, and sometimes it could be related to use of hormone treatments, like in the case of prostate cancer patients in using androgen deprivation therapy, and hormone treatments actually also lead to, we all know, osteoporosis, especially ADT, and then those breast cancer patients that are receiving aromatase inhibitors. So, and when the bone integrity is compromised, and if a fall does occur, that can potentially be quite catastrophic if bone fracture occurs. And for patients receiving radiation therapy, in particular those who are receiving the radiation in the abdominal area or the pelvic region, obviously, that can actually impair bone blood supply. Again, that can compromise the integrity of the bone in that area. So again, making them more susceptible to a bone fracture if a fall occurs. And we all know about myelosuppression and the fatigue that is associated with anemia. So these are just some of the factors. And a recent study actually that Martine and I we conducted actually found that falls and injuries can impact cancer treatment in this population. Okay. And there is actually quite a bit of evidence in the general older population that based on systematic reviews, that exercise interventions, in particular that which targets strength training, or we call resistance training, and balance training, can help prevent falls and lower fall rates in the older adult population. But based on recent systematic reviews, there really isn't much evidence for older adults with cancer. As we all know, they have quite unique risk factors for falls. So that is obviously a gap in research. And on top of that, given that we all know what's been going on the past almost 2 years now with the COVID-19 infection, so oftentimes it's not really safe for older adults to be in a in-person or group-based environment. So that is also one of the impetus for the design of this study. So the objective of this study, obviously we talked about the feasibility. That's actually the primary objective, is to look at an 8-week exercise intervention that is remotely delivered. And we also, a secondary research question is to look at some of the preliminary effects on lower body strength and balance in this population. We used a simple pre-post design, mostly because of the purpose of the study is just to look at feasibility. And we had a targeted sample size of 25. And for that reason, to take into account of an approximate 8 to 10% of attrition rate based on similar exercise studies in the older adult, older cancer population, we decided to recruit at least 27 older adults. So because of the COVID pandemic was going on, we were unable to actually enter the cancer clinic to directly recruit patients from there. So what we did was we disseminated information about the study to physicians and nurses at the Cross Cancer Institute, which is a comprehensive cancer center in the Edmonton area, and also to the clinic staff at the Cancer Rehabilitation Clinic. So the inclusion criteria, we were looking for older adults in the community, age 65 years and above, who were diagnosed with one of the 4 most common cancer diagnoses in this population. And we're looking for patients who were receiving active cancer treatment or who received treatment over the past 6 months, and they had to be deemed suitable to participate in the exercise program. And we used the PAR-Q questionnaire, which is actually a very a short questionnaire just to do some basic screening to see if there's anything that is contraindicating participation. And in terms of exclusion criteria, so obviously for safety reasons, and we did not include any persons with brain metastases or any unstable bone metastases or any conditions that could interfere with their ability to undertake the exercises, anyone who has syncope episodes recently, or who were participating in other exercise programs during that period of time. And we received the ethics approval from the University of Saskatchewan and also the Cancer Committee of the Alberta Health Research. So how it worked was, so after informed consent, the participants received an orientation session. So where the certified exercise physiologist actually provide an overview about safety precautions when exercising. There was advice in terms of how to pick the best spot in their, wherever they were exercising, in the living room or in their room, the chair placement and things like that. And they also went over all the exercise with them, the routines and maneuvers, how it's done. And they also had orientation to help them become familiarized with the online exercise portal. We used Physiotech to help support participants each week. And we'll talk more about that. And also with the online meeting platform, which is Zoom, that we used. And after each participant has become comfortable with the technology and also with the exercise routines, then we'll be the exercise training for 8 weeks. And they have to participate 3 times a week. The intervention itself, we based it on the Otago program, which is known to target lower body strength training and also balance training, and is known to be effective in reducing falls and fall injuries in older adults. And we also follow the progression regimen, and so that the exercise will progress in difficulty based on the person's baseline performance and also their improvement during the intervention, and that's monitored and titrated by the CEP each week. Again, the format, as I mentioned, is 3 times a week. So that's broken down into virtual and independent. For the virtual component, the participants are divided into smaller groups. That's for pragmatic reasons, so that it's easy for safety monitoring. And so each group would meet once a week via Zoom with the CEPs. And so for each session, is approximately 45 minutes plus the warm up and providing instructions and things like that. It comes to about an hour. So we have 2 CEPs. One would oversee the entire session, and the other CEP will be responsible for safety monitoring. And we also had a practicum kinesiology student present as well to help demonstrate the exercises. And then for the independent component, so after the Zoom session, they will perform independently in their own time, 2 more sessions with support of the Physiotech portal. So some of the key features of this program is that first, the CEPs are all trained in terms of working with cancer patients. They know about cancer disease process and the treatments and side effects of treatment, some of the safety precautions that they really need to be specifically careful with when working with patients with cancer. And also we had the patient support portal, which is the PhysioTech that helped individualize the training and progression regimen for the participants. And also another thing is because being with the group together, and because research shows that a lot of patients with cancer, they really value that sense of community, that camaraderie, but at the same time, oftentimes some of the barriers to participating in group exercises, location of that exercise venue and transportation. Sometimes their patients may say they don't have time, or some of them have responsibility caregiving themselves. So these are some of the barriers, and obviously because of COVID, so it would make sense to move things online to make it available to people so that they can participate from the comfort and convenience of their own space, and also to remain safe as well. So this is just a couple of screenshots from within the PhysioTech portal. As you can see on the left here, this is just one of those videos that are available on PhysioTech, and they actually, aside from the text bullet, step-by-step instructions, they also have these video clips that the participant can click on and watch and to follow the maneuvers. And then and when participants perform each maneuver, like the calf raise and grapevine forward lunge, these are the strength training routines, and they can actually record themselves that they have completed, and they can also rate the level of the perceived difficulty, and that will help the CEP in terms of assessing whether they're suitable for progression, or if they will be remaining in the same level. So that's helpful information. And aside from that, we also made extra videos to support the participants. For instance, here you see it's just a screenshot of the video of one of our 2 CEPs. So she's demonstrating 2 different levels of the same exercise. Or for some participants, they might be able to manage a more difficult level. Maybe some things that involve more resistance or more repetitions for each set. And also they will also demonstrate the same exercise, but with a lighter level to make things more individualized. So and participants can choose which level with the advice of the CEP to start with during the training. So safety considerations. So at the start of the study, we identified the support person for each participant, and also for emergency contact, especially for those who are living alone and who don't have anyone. And sometimes we might enlist a neighbor or a friend whom the person can contact. But overall, the exercises, because they are largely chair-based, and some of them are performed while sitting on the floor or in lying position on a mat. So they're relatively safe, and the fall risk is not high. And also, as I mentioned at the beginning, during the orientation session, and also at the beginning of each session, we also remind participants to about the setup, make sure the chair is tight against the wall, or make sure you're by a sturdy table or a counter and have something to hold on to at all times. And even though some of the balance exercise might involve graduating from holding on to the structure to letting go and not touching, and you have to maintain a balance in a certain position, but still something is always within reach. And also they're advised to remove any clutter or fall hazards in the area where they're exercising. So in terms of outcome measures, obviously the first one, feasibility, we looked at some of these elements. And then for the other piece, for the second research question, for lower body strength, we used a 5 times chair stand test. And then for balance, we measure basically static balance instead of dynamic balance. So that's a bit more feasible because it's in front of a camera, as opposed to being in an actual room where you can actually turn your head when a person is walking from point A to point B. And then falls is, we call it based on self-report, but actually the participants are asked to record that on their PhysioTech portal, and that's a weekly question. So there's sort of like a fusion between fall diary and self-report. We collected the data in terms of the outcomes, lower body strength balance and falls at baseline, and then at 8 weeks. Just simple analysis, mostly descriptive, and we did do some pre-post comparison for research question 2, but that's just, but obviously it's a very small sample size, and again, it's only 8 weeks, so we did that not really to answer the bigger research question. That would be something that we'll do in the next phase, but just to produce some preliminary parameters to help with sample size calculation for our next study. And this is what we found. So we recruited 27 participants. The mean age is 70. As you can see here, the oldest participant is only 76 years old. It's quite balanced in terms of gender. The majority of the cancer sites were breast cancer and prostate. About half, well, actually more than half of the participants were receiving active treatment. And one participant withdrew from the study midway. And actually it was before we hit midway, but that was for reasons that was more personal, that is not related to the study itself. And during the entire intervention, there were no adverse events reported or observed. So, and just to add, among patients receiving active treatment, the majority were receiving hormone, and about 12% were receiving chemotherapy. And again, because of the COVID pandemic, we're not allowed to enter the cancer center to receive, to collect more data from the person's medical chart. So some of the things like cancer stage or more details about the treatment were not available. So in terms of feasibility, we're able to recruit, well, the recruitment was 60%, and that was based on the dissemination from the clinicians, from the doctors and nurses, and attendance was really good. And for the Zoom component, as you can see here, is over 97% of attendance rate. And for the independent component, where they have to do individually and record it on Physiotech, that was pretty good as well. It was close to 85%. And so except for that one participant who withdrew, we had a 96% completion rate. And in terms of outcome capture, out of those 26 participants who completed the study, that was 100%, which was really good. Didn't have any missing data. And in terms of program feasibility, we didn't receive any comment related to difficulty in using the technology, be it the Zoom platform or the use of Physiotech portal. So, and in terms of how they liked the program itself, we did receive some pretty good feedback about the program. Participants were happy, they felt that it was rewarding, and they would actually like to continue to exercise on their own. A few participants actually wanted to us to continue, but unfortunately, because the cutoff was 8 weeks, so we had to end the program. So in terms of preliminary efficacy, so there was significant improvement in terms of lower body strength as measured by the 5-time chair stand test. But again, this has to be interpreted with caution because of a very small sample size, among other things, which we're going to talk about. And for balance, it was only borderline, and that we didn't find any significant finding. And one of the reasons may have been because of some of the, actually most of the participants were quite high functioning. So there was a bit of a ceiling effect going on there. And falls, we decided not to compare falls because it did not really make sense, being it's such a very short follow-up period, the time frame of the study, and also a small number of participants. But it's but still, it appears that there's less fall, but this may have been related to the next thing as well, which is, again, this is something that we weren't looking for, but it's just an interesting observation. Just want to share here the fall efficacy. So it seems like participants became more concerned about falls, which seems to be counterintuitive. But it may have been related to, again, the fall rates as well, which is being in a study right? That is about fall or preventing falls, so may have increased participants' awareness about falls and fall risk and these, this kind of thought process. So that might have in part contributed. And also in terms of the timing, when we collected the data for baseline, that was well into fall in Canada, and especially in this Saskatchewan region, which is sort of like in the Midwest, and we have early winters. And so by the time we collected the outcome, which is sort of end of intervention data, that was well into winter and obviously snowy, icy conditions. So it's not abnormal that people were more concerned about falls. So some of the limitations about the study, as I talked about, it was a small sample size, and we also had a very short intervention and follow-up period. So again, we have to take these into consideration when interpreting some of the findings, especially the findings related to preliminary efficacy. But the primary purpose of the study was to look at feasibility, which we're able to address that research question. But then again, there wasn't major challenges related to use of technology. We did have some hiccup, which was quite rare as well in terms of when we were collecting outcome data. So there was sort of like internet interference related to video lag with one participant. And because prior to the start of each assessment session, we would advise the patients or the participants, if something gets cut off or if your internet suddenly cuts out, don't worry, just continue counting. We'll also advise their caregiving person, if there is one next to the participant, to continue counting and things like that. So for that particular case, because their internet was quite unstable, so we had to reschedule the session, and that was only for one participant during one session of data collection. But the rest of the time, it went quite smoothly. And another limitation would be the lack of representation of the older age group, as you could see earlier in the demographics. So we didn't have anyone who was older than 76, so that obviously was a drawback. The majority of participants were quite high functioning, so that's something to look at as well. And because of COVID, we weren't really able to go in the clinics and recruit directly. So we use another method. So that might have contributed to some of the sampling bias, because those who called us to say they want to participate may have been a more motivated group to begin with, and who are more aware of the importance of exercise and who are interested in exercising as well. And again, single site recruitment, it was only one site, but we do look forward to the subsequent study, which we will try to recruit a more diverse sample size, samples in terms of age group, and patients with or without technology. Even though for this one, we said we would be providing assistance with technology, and we can loan iPads and provide internet access. But for this particular sample, they all had devices and internet access. So that was great. So to make a long story short, the remotely delivered exercise program appeared to be feasible in this population and may have potential to improve lower body strength in this population. But obviously, we need a larger study that involves more to continue to explore this research question. Thank you.
Thank you, Shoto, for that presentation. That was very nice. So now we open up the floor for questions. Does anyone have a question?
Thanks very much for the presentation, Schroeder. Really neat to see your work develop into a full-scale intervention like this. It's neat to see that progression. I was just wondering, and I may have missed this as you were speaking, also exciting to see that it's happening in Edmonton. There's so much needed here, so it's really lovely to know. I'm just wondering about how that recruitment unfolded. Like, I noticed at the beginning, you were collaborating with the rehab clinic. So was it people who were referred to the rehab clinic who had access, or was it a broader invitation? And I apologize if I missed this, or was it, did you connect with certain oncologists, or how was the recruitment invitation distributed?
Thanks, Faye, for the question. So for the rehab clinic, actually, the site PI and the Edmonton side, they actually, they are involved in the rehab clinic as well. So they actually disseminated the information through the clinicians who were directly in providing care for the patients who referred there. So they actually provided information. So the same thing as the ones from the Cross Cancer Institute. So if they were interested, they would be calling us. So there was no direct recruitment involved as opposed to something that we would have normally done and when it's not COVID time.
Of course.
Yeah.
But
so
then,
that might
sorry.
have, sorry.
Yeah.
So that's a really important thing because of the fact that we had to involve the cancer rehab clinic. So that may have been in part led to some of the participants who were more aware of the importance of exercise and who were interested and more motivated as well. So as I said, there may have been a sampling bias going on there. Okay. Again, that's what we could do within the constraints of COVID, which is paradoxical.
Yeah.
It presented the opportunity for us to do this, but then again, there are also drawbacks.
Yeah, no, of course, and very interesting. Do you have some ideas of how to sort of overcome that in the next stage of the study or reach, maybe more older population or a less active population?
Yeah, we were hoping that with obviously the pandemic is not going to end anytime soon, but with things seem to be slightly improving, we're hoping that we can actually get into the clinics when that is allowed by all the research ethics boards, which is another layer of challenge, to directly work with the physicians and the nurses to identify participants who will most likely benefit from the intervention. So we're still waiting, say, for Cross Cancer Institute for now, based on what we understand, they are still not 100% like green lighting things, even though things are starting to open up. So we're hoping that as things get better, and it's same thing with the other potential sites as well. So that's what we're hoping to actually get into the clinics next time and be able to identify patients who will most likely benefit the most, because we will still look at feasibility in terms of obviously the technology size is a piece, but we also really want to look at in more depth in terms of how it really improves people's lower body strength and balance. And with a longer follow-up, we really want to look at what it does to falls as well. So
thank you. Thank you.
Thank you, Faye.
Okay. Are there other questions from anyone?
Yes, maybe. I would like to congrats you for the successful concerning this study, which is your work is very impressive. I wonder if the patients benefited from geriatric assessment at baseline or to control the other risk factors for fall.
Thank you for the question. That would have been ideal, but again, we weren't really go into the clinic and do anything at all because everything was literally sealed off. So we had to disseminate information about the study through clinicians, and so a lot of things that we wanted to do. So obviously, a geriatric assessment would have been great because we could have identified a lot of things that could help inform us about the participants and help really go into more detail about the tailoring. But like I said, like the other things, like getting into the chart, simple things like that to see the disease stage and what treatment are they actually receiving over and beyond, okay, hormone, chemo, what kind of drug, and for how long exactly, when did it start, what are some of the comorbidities and medications, some of the stuff that we really wanted to get from the chart, but we weren't able to. So, but again, hopefully that would be a really good idea for the next for the next phase. that would really help.
Thank you. I would be interested to participate to this kind of a study if you would like to expand it at international study. So it should be interesting.
That would be fantastic. Yes.
Any other questions? Then I'm going to ask a question. Because you mix people that were new starting treatment and people that completed the treatment, and there may be difference in prevalences of neuropathy and things like that. And I know the sample size is very small. Did you see any differences in feasibility or preliminary effects in both groups, or is it the same, or it was too unbalanced to look at that?
It was, to be frank, it was actually, you're right, it's quite unbalanced, and because it is a very small sample, so we didn't really make any other comparison based on treatment, like for how long, or the intent and things like that. We weren't able to look into those things. But I think it would be, and because of the challenges related to the recruitment, so we actually had to go the route of the cancer rehab clinic to supplement the recruitment from the Cross Cancer Institute. So hopefully that's actually one of the drawbacks as well. So hopefully when we're doing the next study, that would be patients that are more, it would be a bigger sample. And if we're mixing patients, we still want to do that because sometimes peripheral neuropathy, they don't really cease as soon as treatment ends, so they might linger. So we thought it might still have value to include patients who are receiving treatment who have recently just ended treatment, but not for too long. But if we have a bigger sample size, so we might be able to divide or separate things and analyze separately and see if there are any patterns that we may notice that stands out. But that's a really good question, Martin.
Thank you. Are there any other questions from anyone?
Jump in with another. I was just wondering if you kept track of if there were any rural participants. Just thinking that something virtually like this may be particularly attractive to people in the rural areas. If you noted if people were from more remote areas, or if everybody was pretty urbanly located.
Basically, the majority of the patients were quite urban because they all lived within the metropolitan area in Edmonton. So yeah, it was, so again, is not really representing people from the more remote region, which is especially important in our locality because most population are not in the big urban centers. So again, the representativeness of the sample.
Thank you. Are there any other questions? If not, then I would like to thank Schroeder for presenting this work, and we look forward to learning the next study result, hopefully with more normal circumstances and no COVID. And then I would like to thank everyone for joining today, and we apologize. It's Friday night in Europe. We totally didn't think that through, but yes, we will try to move it away from Friday evenings, not to take up your weekend. And if anyone on the group has something to present or has ideas that they would like to hear more about, or great speakers that would be interesting of the group, let me know, because we're really trying to be helpful and collaborate. So if you know someone that you think would be great, or you have something you would like to present from your own project, it doesn't have to be a big or finished research project, or you would like the group members' feedback, then please let me know, because we're happy to plan more webinars, and we do them as you volunteer, and you can pick the date and time that works for you, and then we'll invite everyone, and we may have varying levels of participation depending on the time of day and it is, but we post all our webinars for our SIOG members, our NIH members on our website, so anyone can access that, who's a member can access them after. So thank you so much, and then have a lovely weekend, and then we'll see you at our next event.
Thank you, everyone.
Bye.
Bye.